have a lot to talk about today. And so I think the best place to start off would be what motivated you to become a doctor? And just tell us a little bit about yourself.
Yeah, absolutely. So I have a pretty non-traditional or atypical pathway into medicine. I originally in undergrad studied history, specifically African history. And at the time I was working for the school newspaper and really kind of got into journalism. And that was kind of my thing in college and thought I was going to end up a journalist. Um, and I really over time realized that the majority of the opportunities when I finished school in 2004 were really shifting to the online space at that time. And it was less about being a reporter out, in the field getting interviews and more sitting in front of a computer and reworking headlines and kind of regurgitating the same stories. So I did that for a short period of time after college and realized it just was not like fulfilling me on a bigger level. And so I like to describe my post college time as like, I just kind of bounced around and tried to explore what felt like the right fit for me.
Mm,
So I worked for a few months doing some freelance journalism. And then I worked for a law firm for a year and change that actually represented journalists and other media entities. So I got to really get into the weeds in First Amendment law, which intellectually I found very intriguing.
yeah.
But on a day-to-day basis, I was like, I don't want to be a lawyer. So
Yeah.
I learned that in that job. And while I was in that job, I kind of always had this feeling of like, I just want to learn. I love learning. And so I ended up taking a class in the like evening classes at the college where I went. And the class was called Clinical Research in Emergency Medicine. And I signed up for it because I thought, that won't be boring. I know nothing about this. I'll learn something. It'll be kind of interesting. And it was a class where you really learned about what is clinical research? What does that mean? In a didactic format. So sitting in a classroom, learning that way. And then you actually got assigned to a clinical setting to
Mm,
basically perform clinical research. So I got assigned to the emergency department. My job was to wear a cute little gray coat and walk around and enroll patients into, they had at times between like 10 and 20 studies running in their emergency department.
well,
So I went around and looked at all the patient charts and tried to identify patients that qualified for studies and then go in and counsel them and say, hey, are you interested in participating in this study? So during that, like basically I was paying to work in the emergency department
yeah.
via
I
a
know that.
class.
Yeah.
I was like, shoot, I really like this. And what I liked about it was that it involved, you know, being smart and getting to use your brain and doing a lot of reasoning, but it was also very interactive. It was
Mm,
all about sitting down with a patient, hearing their story, getting information from them, and then also going to colleagues, whether it's other residents, attending physicians, nurses, collaborating, working together in a team-based environment to come up with a solution and a plan. And I was like, this is exactly what I've been missing sitting behind a computer as a journalist, sitting behind a computer as basically a paralegal at a law firm, was that like real human connection. And for me, the light kind of went on that um, in order to provide medical care, you have to get to know your patient. And so
mm,
kind of embedded in the role of being a doc is talking and hearing stories. And so in some ways I was like, this is almost what I thought journalism was going to be, is like
right.
hearing stories, eliciting stories, and then doing something with those stories. And I actually felt like I had more to do in a medical setting than I ever was able to really accomplish by just telling the story, in writing. So that's what kind of piqued my interest. That being said, I was like 3 years out of college at that point. I had studied nothing related to science at all as an undergrad, nothing. And so I was like, uh-oh, I do not want to call and tell my family and friends that I think I want to go into medicine because they're going to think I'm a lunatic. So
Right.
I ended up staying on and working in the emergency department at night and gaining a lot of experience over a year or so, and really realizing that it seemed like the right decision for me. So I gained some more experience. Um, and then I also just did a lot of reaching out to folks in medicine and really trying to understand what would be the best pathway for me in medicine too. At that point, I was, getting a little bit older. So I thought maybe I shouldn't become a doctor. Maybe I should do nurse practitioner or PA route. So I really kind of weighed all of those options, and ultimately decided to become a doc because it, from my perspective at that time, which I do feel like this has come to fruition, it just leaves lots of doors open. So it allows you to both gain skills in clinical care and be a full-time clinician seeing patients if you want to. But I think the MD also affords some flexibility to move into other spaces with respect. So whether that's advocacy, or, advocacy for social justice, or, I just felt like I could kind of use my degree in different ways. Research is another example. I felt like I could really flex into those spaces if I wanted to. So I ended up doing a lot of research, and there are these programs out there for people who should have taken all the prereqs for med school and college, but didn't because they were
Hmm.
studying something else. And they're called post-baccalaureate pre-medical programs. And there happened to be a really good one outside of Philadelphia, which is where I was living at the time. So I went to Bryn Mawr for 1 year and did all 8 prereqs for medical school in a
Wow.
12-month period. It was an intense 12 months,
Sounds
but
very intense.
yeah, definitely worth it to me to just kind of get it all done
Of course.
really quickly. And then I ended up directly linking to medical school at the University of Rochester, which is where I went to medical school.
Nice. And
Um,
that's where you're at
yeah,
right now, right?
yes, it is, ironically.
Well, it's great. I mean, I think it's interesting that you started off in like interviewing skills, because one thing that I hear with doctors or anybody in the medical field is just like paying attention to detail and getting all the information out, or getting everything from the patient. And the fact that you had that as like a subset of requirement or a subset of information for your degree, I think it puts you at a different, I mean, interview skills are huge.
Yes, yes. I do feel like it kind of was a leg up. I think too, I also have subsequently gone on to do some teaching in medical school. And I find, and you can probably identify with this too, but one of the biggest skills that you learn when you go into any healthcare profession is like basically that like confidence to walk into the room and introduce yourself and say, hey, I'm here to take care of you today. What's going on? And I
Mhm.
think the other thing that I came in with is like, I just kind of had that ability to go in and start to talk to people because that's something I had to do as a journalist. That awkward feeling of like, oh, I'm going to walk up to this person that I don't know at all and
Yeah.
just try to get into it with them. And so I think that came a little bit easier to me, and I think has made, is probably one of the reasons why I've ended up in places like primary care too, where really the crux of my job is understanding someone's life,
Mhm.
understanding their context, understanding how they live, what their family is like, and really getting to know that to understand what treatments might be effective for that person.
Yeah,
Um,
and it seems like anytime someone has like a midlife crisis, or at least from what I've heard, is like I feel like sometimes when people switch, they're always like, "Why? There's no human involved in this," and then they're always looking for something more human, or at least interacting with a human, or helping somebody else out. So maybe for somebody out there who's like struggling to figure out if they don't want to be an accountant anymore, maybe it's working with somebody or working with humans in general might
yep,
be your solution.
exactly, exactly. And look into post-bac pre-medical programs because they're
Yeah.
they're out there for if you're like, but I didn't take any of the classes. Don't worry, there are programs for us indecisive folks.
And so you get into medical school and you're in Philadelphia still?
I actually, yes, I got into medical school when I was living in Philly, and decided to move up to Rochester for medical school. So
Oh,
that's where
that's
I
right. Yeah,
did my medical school degree. So I moved from Philly up here, I'll be honest, because living expenses are about half of what they are in Philadelphia and
for
Rochester,
sure.
New York. And that was really the most intimidating part of going to med school was going from being a functional adult who paid all of her bills to, oh my gosh, I'm about to go into a lot of debt. And so I was very conscious of expenditures and trying to make it as least expensive as possible, which
It seems like you're very conscious of that. Was that a was that a non-negotiable where you're like, I don't care about the money. I really want to do this the rest of my life. Was that something that you had thought of beforehand or maybe regret now?
great question. There are days I have push pulls around this. I do a lot of advising to a lot of medical students, but also some people who are thinking about going to medical school. And I don't think there's an easy or short answer to deciding between like a nurse practitioner or PA route versus the MD route. Because effectively in a lot of healthcare, you can do a lot of really good work as a nurse practitioner or physician assistant in our healthcare system. And actually at Planned Parenthood, where I work now, I'm actually the only physician on staff and I oversee 22 mid-level providers or advanced practice clinicians, which kind of is the all-encompassing term for nurse practitioners and PAs. And they're fantastic. They do the vast majority of care across our 9 clinics. And so it's a really tricky decision to make, I think. I was very conscious of how much this was all going to cost, which is why I really considered the nurse practitioner and PA route for a long time, but ultimately felt like I have just a little bit too much of a curious personality. And I was always going to be like, I wish I could go do research, or I wish I could do these other things. So I kind of ended up reasoning to myself that it was worth the additional investment to be able to flex into different spaces down the road in my career. But I don't know, there are days where I go in and sit with my PAs and MPs and I'm like, oh, I wish I was a PA today. And they
Yeah.
joke with me and they're like, yeah, it's, there are pros and cons to each pathway, I think. And they joke with me all the time that I'll be paying my loans back for longer than they will be, which is true,
Yeah.
So
But I think, again, like you said, like you did learn, I mean, you do learn a lot in all programs, of course, but I think being a physician, just having that extra knowledge and being curious, I think is something, almost a solution to, like, learning more is the solution to the curious mind, is what I was saying. And I meant to say, and
yes.
you need a little bit more, just a little bit more. You're like, if you went through all that, maybe inside, although it's going to cost more, like inside, you're like, okay, like I would rather know more than not knowing and being like, oh, so and so will know. Like, you'd rather have that knowledge, or at least the answer to the question, right? Because part of when you're doing an interview, I'm assuming when you're doing all your, like, asking of, like, finding out a story or
Mm-hmm.
whatever, part of being a doctor is asking the questions, finding out the story, but then also providing solutions, which may, not always be the case if you don't get as much information. So,
Right. Yeah.
yeah, I think doing that extra route, if you're definitely curious, I think more information may be that solution.
Exactly. And, I find when people say to me, like, what do you think is the big difference between a doc and a mid level? Is I say, I think when things are kind of like, I don't want to use the word straightforward because that's not actually what I mean, but when things are kind of logical, I think my NP and PA colleagues get to the same conclusion I do, probably at the same amount of time. It's when things don't follow the normal patterns and you
Hmm.
really have to go, well, what else could this be, or why is this presenting differently than we commonly see? I find those are the times when I have just a little bit more of a repository of information to go to and go, well, it's not fitting this picture perfectly, but kind of how can we look at this differently? And I think because of the additional, frankly, time that we get to learn all of that stuff, we just have like a deeper well to go to when things aren't exactly straightforward or don't present exactly like you read in the book.
Exactly. Yeah. And it's more of an art form, right? That's why, like, yeah, practicing physician, you're practicing, always learning something new. And for
Absolutely.
you, when you got into medical school, did you want to go right into the route? Like, did you know that you're going to be Planned Parenthood, or, like, what did you start off wanting to pursue?
Yeah, great question. I definitely came to medical school with like a totally open mind. I actually spent most of my time in journalism writing sports. I was
Mm.
a big athlete growing up and I played a lot of soccer. And when I stopped playing soccer in college, there was this like void in my life. So I started writing sports for the newspaper. And so I really had this background in sports. And so I will say, like, when I came to med school, I was like, maybe I'll be an orthopedic surgeon. Like, I know a lot about the knee because I've heard it a bunch. So and I mean, that really goes to show like I was bringing my personal experience with
Right.
physicians. And really, that is the majority of who I've interacted with is orthopedic surgeons at that point in my life. So I definitely thought about that. Um, but also, I think for me, from the moment I arrived at medical school, I do think I was already conceptualizing of my degree as an opportunity to also be an advocate. And so social justice initiatives have always been an important part of my life. I think I've kind of always been the feisty one out there pushing for change or, you know, uh, I guess pushing for progressive initiatives. And so I did come to medical school thinking like there is a way to use my medical degree to also push for some of those social justice initiatives that are important kind of to my life in general. And so I always had that lens of social justice too, which Early in medical school, I got involved with a few organizations that are considered kind of progressive social justice organizations. The American Medical Student Association, or AMSA, does a lot of advocacy and is thought to be kind of the progressive organization, whereas the AMA, the American Medical Association, is thought to be more of kind of the old stodgy institution. And then I also got involved with Medical Students for Choice, which is an organization that supports abortion and contraception and reproductive health training in medical schools. So I also got involved with that organization, which kind of piqued my interest. I guess I, from the get-go, was trying to think of like, what are ways that I can use this degree to help serve people who are underserved, or the term I've really enjoyed that I've heard, not enjoyed, but I think is really accurate, that I heard recently is folks who've been purposely ignored, right? Whether
Mm.
that's due to systemic racism or due to stigma of what care they need. Like, I always did have this feeling of I want to be able to use this degree to address some of those inadequacies in our society. So those were kind of there, which does not really like work with orthopedic surgery, right? Like those don't really dovetail together.
They're not really in
Um,
the same realm.
exactly. So I think I got into my clinicals in third and fourth year. And basically, I'll tell you, I basically realized I loved everything but the OR. The OR just
Interesting.
wasn't my jam. I just didn't like the operating room. I'm a pretty chatty person and pretty interactive. So I was like, unconscious patients, this is no fun. Like, what am I doing here? I also like lovingly describe myself as a very functional person with like not the longest attention span. In that, some surgeries, man, you're looking at a space this small for hours and hours. And I was like, this is boring. I
Yeah,
want
not
out
for
of
me.
here. I'd much rather, have a really interesting hour-long discussion with someone who's coming in with complaints. So for me, it was clear the only thing I didn't really like was the OR.
Mm.
So I kind of took out orthopedic surgery.
Yep.
Um, and so uh, I then spent a lot of time thinking about, well, what part of medicine do I love? And ultimately concluding, I kind of loved it all. And every time I thought about specializing, I got cold feet. It's the only time in my life that that phrase has ever resonated for me, of getting cold feet. But I'd
Hmm.
think, okay, I'm going to do pediatrics. And then I'd be like, I'm never going to see an adult again. Or I thought about becoming an OBGYN. And I thought, then I'm never going to see a male patient ever again. Like, that's crazy. I
Right.
know so much about male bodies as well. Um, and I also loved neurology. I found neurology totally fascinating. And then I was like, oh, but if I do neurology, like, I'm never going to hear about a sprained ankle again. So I just kind of got cold feet and realized I liked having tools to address a lot of different things. So that's when I decided to go into family medicine and really keep my training broad. And I will say that when I was making that decision, becoming an abortion provider was part of the calculation. Abortion care is very underserved in our country. There aren't very many abortion providers, particularly in rural areas, particularly in areas that identify as more conservative or more rural. Um, and so I saw this as a tangible way to affect some social justice change. Just by acquiring the skill set and being able to do that procedure, I was, effectively pushing back against the system and getting to advocate for patients. So being able to provide abortion care was very important to me, which kind of narrowed it down to basically family medicine and OBGYN. And as I mentioned, I didn't like the OR, which my best friend is an OBGYN, and I called and I said, what do you think? What if I do OB, but then just deliver babies and do abortion? And she was like, do not become a surgeon unless you want to become a surgeon, which
Right.
was great advice, because she said, you're going to be miserable for half of your residency in the OR. So I ended up going to family medicine, and specifically targeted and picked a family medicine program that I knew would adequately train me to provide abortion care. So I then really focused on finding a family medicine program that I knew would give me the skills of abortion training and then also be able to take care of obstetrical patients. I really wanted to know how to deliver babies and be able to do that competently. So that's how I targeted my residency program. And I ended up moving to Seattle for residency, where I trained at Swedish Cherry Hill Family Medicine Residency, which is a very well-regarded program, a community hospital-based program, where you get to do a lot of really great care that's community embedded. I worked at a fantastic clinic in Seattle called Carolyn Downs Family Medical Center. It was originally founded in the 60s by the Black Panthers as a form of resistance because Black folks could not access medical care. So one of the ways that the Black Panthers resisted was by creating clinics where Black folks could actually show up and get care.
Hmm.
So that was the origins of the clinic, which really fed that social justice theme and part of medicine that has really been foundational and important to me. So I learned a ton at that clinic and worked with some really great patients in that area and trained there for a couple of years. Ended up meeting my husband in Seattle, who ironically is from Rochester, New York. And so we ended up moving back to Rochester, New York, which I did not see coming.
Right. It's
And
kind
I
of a
spent
vortex, Western New York.
it's funny. And now I'm like, kind of love it here. I don't know if I'll ever leave. I was just literally texting today with the farmer that I'm going to do my largest CSA with this year. And one of the coolest things about Western New York is that we are just surrounded by people who grow food. And so we are very lucky, my husband and I, in the summer months, basically from like May to September, we eat food that we literally know where it's grown. We know the people who grow it, their friends. It's not just our vegetable growers. I have a flower CSA this year, so I get my flowers from a friend who has a farm down the road. We have friends who own a pig farm around here, and one of our good friends owns a butcher shop in town, and they source all their meats locally. So we are really lucky to be able to
Very
access our
connected.
nutrition, yeah, locally. So.
And so now, after your residency, you're in Seattle. You meet your husband, and you move back to Rochester for the Planned Parenthood gig that you're at right now.
I actually moved back and for a couple of years did full spectrum primary care, meaning I saw patients for primary care, adults and kids, and then I delivered babies. And then I actually worked at Planned Parenthood in a contract or per diem basis
Hmm.
for those first couple of years. I would just come over and provide basically abortion care a day per week while also maintaining my own practice. And I did that for about 4 years. I also had the opportunity in those 4 years to do a little bit of teaching at the medical school. And since 2015, I've actually been on the admissions committee at the University of Rochester Medical School, which I really like because it keeps me hip and keeps me plugged in with the kids and all the new stuff. And yeah, keeps me pushing forward and learning new stuff. But after about 4.5 years, Planned Parenthood came to me and said, we're really interested in rolling out some new services, and our current medical director, basically doesn't do this type of care. So specifically, they asked me about gender affirming hormone care. So providing masculinizing and feminizing hormones to folks who are gender diverse, whether that means trans or non-binary. And the medical director who was in charge at that time basically was like, I was never trained to do that. Let's reach out to Dr. Potter and see if she can come over and provide those services for us. So in 2018, I actually moved over to Planned Parenthood full time and continued to provide my abortion care, but then over the course of 6 months kind of propped up and created a gender affirming hormone care program too, which we implemented in the fall of 2018. And we've been providing those services for over 2 years now, which is really exciting.
Yeah.
Shortly after I came over to Planned Parenthood for that role, the medical director actually stepped down so that she could then go be the national medical director of Medical Students for Choice, which is that
Hmm.
organization I mentioned a few minutes ago. And so I ended up taking over as medical director kind of unexpectedly on that timeline. It just all
Hmm.
happened a little bit quicker than I was expecting. So I've been in my current role for almost 3 years, going on 3 years, which is a combination. It's an interesting role because it's a combination of clinical care, administrative and operational work within our organization, and then also some national considerations as well, whether it's nationally having to stand up and advocate or collaborate with my colleagues that run other Planned Parenthoods across the country, or work on committees on a national level where we talk about what are the protocol changes that we want to see within Planned Parenthoods. So it's a really cool role because it's like very interdisciplinary. I do not show up and do the same thing every day.
Yeah.
I get to do something very different every day.
Yeah. That's what I kind of want to ask you is, Planned Parenthood is kind of It's obviously a hot topic, of course, and
Mhm, mhm,
everyone has their own viewpoint, but I feel like not
of
everyone
course.
understands what it is to some degree, because you're talking about gender reassignment, you're also talking about abortion, but then you're also talking about all these social changes. And so I think I want to start off with, like, what is not Planned Parenthood? Like, what is, like, are there misconceptions that people believe Planned Parenthood is, and then maybe we can go off of what it's not to what it is.
Yeah, great question. I like how you put that. Um, so the first thing that I think will kind of be a helpful framework, I end up explaining this to a lot of people, is that Planned Parenthood is kind of like a franchise model in that there is something called the Planned Parenthood Federation of America, and I would call that like, McDonald's, like the overarching franchise. And Planned Parenthood Federation sets some standards and basically says, in order to say that you're a Planned Parenthood, you have to do these things. Same
Mm,
thing at McDonald's, right? In order to be a McDonald's, you've got to offer the Happy Meal, you've got to offer all these different things. And Planned Parenthood is basically the same way. But then each individual Planned Parenthood affiliate is its own entity, but
oh,
it
okay.
still has to um, follow the branding, the medical protocols that are set by the national organization. So I work for an organization that's called Planned Parenthood of Central and Western New York. So we offer services across, I like to call it the I-90 corridor of Western New York here. So basically Buffalo, Rochester, and Syracuse are kind of in a straight line on I-90. And we provide care in all of those cities and then in the communities in between those
Mm,
cities. Um, so I didn't exactly answer your question there, but I'm getting to it, I promise.
I believe.
So I really have started to, when family members or people who don't know much about Planned Parenthood ask me, I first off say that Planned Parenthood is a sexual and reproductive health provider. And I think that helps people to kind of back away from the sort of narrow view that they often see us in, which is basically like, you guys provide abortions, right? Like it kind of
Right.
gets narrowed down into that very small spectrum. And so I try to really brand it as sexual and reproductive health, which involves a lot of things, right? In order to have a happy sexual and reproductive health life, that may involve treating your blood pressure, or that
Right.
may involve treating your diabetes in order to have a happy and healthy sexual life. So, yes, it does involve birth control. And yes, it does involve abortion. But it also, if you really back it up, it involves a lot more than that, too. So, we offer at our health centers. And so this is a little bit different from health center to health center. So if you're hearing me speak and you're like, hey, I live in New Mexico and my health center doesn't offer that, I'm not surprised because, again, each Planned Parenthood is a little bit different based on your individual franchise. So in our clinics, we offer comprehensive reproductive and sexual health services. So whether that's offering hormone care to gender diverse folks, offering abortion services, contraception services, STI services. We offer PrEP, which PrEP is a pill that you can take to decrease the risk of transmission of HIV in folks who either know that they have an HIV infected partner or in folks who are, engaging in sex and just want that extra layer of protection, or if they know they're engaging in sex in higher risk communities, they can have that extra layer of protection. But then we also do some really basic stuff, right? Like we screen everybody's blood pressure because it's really important and that affects your sexual and reproductive health. We also offer behavioral health screening for all of our patients. So we check in on anxiety and depression
Mm,
symptoms for all of our patients and have really good pathways to getting people connected with care who need it. And then something I'm really proud of, because I'm a primary care doc, and I think literally every health clinic you walk into should be able to talk to you about smoking and how to stop smoking if you want to. We've really done some work on that in our health centers over the past few years. And kind of with that, building up the skills for all of our health center staff to be able to say, let's talk about lifestyle change, whether it's, I want to exercise more, or I want to eat better, or I don't want to smoke, or I'm worried about my drinking. The specifics aren't so important as the skill set around talking about behavior change. It can kind of be applied to anything. So,
mm.
really equipping our health centers with the ability to help people talk about that and strategize about how to make health behavior change. So, what I would say Planned Parenthood is not is just an abortion provider. I mean, I think that is really the biggest misconception out there, is that all that we do is prescribe pills for contraception and then take care of your abortion.
Yeah,
Yeah,
for other, made it as a franchise. And you also said that other clinics don't have the tools that you guys, because it sounds like you guys are really just, you guys touch base in so many different aspects of healthcare that I think are neglected a lot of the time, where you're just having general conversations about health,
right.
generally how you're feeling. I think those things are super important, but why are other clinics or other franchises not as resourceful as you guys are? Is it just because like one McDonald's can be run better than the other one, or is it distribution of funding from this federation? I guess you can describe that a little bit more.
You mean like Planned Parenthood as opposed to non-Planned Parenthood, like health center facilities, like
Yeah.
yeah. You know, it's interesting. Interesting, and my answer is like really, really big, which is
Okay.
I'm going to be honest. Like, I really think the American health system is a failing state right now. Like, I
Hmm.
think it's so flawed that at some point it's just going to bottom out and fail. But and so my really big answer is, I think when you prioritize profit over anything else, um, patient outcomes suffer. And Planned Parenthood is a not for profit organization that is always thinking about how do we best serve our communities and how do we best serve our patients. And I do not think that that happens in for profit medical settings. So
Yeah.
I think that when you're trying to figure out ways to make money on people's health, it's harder to prioritize these things that, frankly, do not get compensated nearly as well by our current system.
Yeah, and I think there's other, I think in the high, I think it's tough for the people in the middle, right? Because like not for profits down low, you can't afford it, but then up top, if you pay a lot of money, you can get the care that you want, right? You can get they'll care and they'll listen, do everything you want, but you got to pay for it. And
Yep.
so that might be the financial constraint that you're talking about. I'm assuming, right?
Yeah. The other thing I should say here is that I am very, very lucky to work in New York State.
Mm,
So much of what happens at Planned Parenthoods ends up coming down to state law.
mm,
So I, as a, working at Planned Parenthood in New York State, we have much more support from our state than somebody working in Mississippi does. So for instance, in New York State, there is something called the presumptive eligibility program for Medicaid, where if you have a positive pregnancy test, you can be rapidly put on Medicaid, like basically by our front desk that same day, and immediately get Medicaid benefits that will cover your abortion and will cover your contraception.
interesting.
That is a state-based Medicaid program in New York State. If you drive across the border to Pennsylvania, you are not going to be able to access that system. So in a lot of ways, I also am incredibly lucky when I get on calls, and I am on the calls with the other 45 medical directors of Planned Parenthoods across the country. Folks in Mississippi are often like, damn you, Dr. Potter, you just get so much more support. Whereas in their states, which, have a different makeup of their state legislatures, they are not getting funding. They're not getting emergency Medicaid programs that cover abortion. And so I also think that that gives us kind of a leg up, frankly.
Yeah. And do you feel that Zoom or perhaps other modes of technology are allowing for better spread or better access of healthcare?
Yeah, I think that that is the new frontier that I'm very excited about.
Mm,
In the past couple of months, really, there have been several websites where you can access the abortion pill by website, which I think is going to become increasingly important. There was some pretty big news this week that the Supreme Court agreed to hear a case about abortion that came out of Mississippi. It's basically a ban that would make it basically illegal to perform abortion at 15 weeks and beyond. And that's going to be heard by the Supreme Court. And I do think there are some pretty big repercussions that could come out of that decision. And I don't want to get too far into legal weeds here, but basically, if and when Roe v. Wade is overturned, which I think the Supreme Court taking this case is a really big opportunity for Roe v. Wade to be overturned. Essentially, what will happen is the legality of abortion will revert back to what state law says. So there will be
Mhm.
no federal protection for abortion. So whether or not you can access abortion depends on where you live.
Mhm.
And so in New York State, we have it codified in our state law that abortion is legal. So I think all of a sudden, when Roe v. Wade falls, which I unfortunately think will likely happen in the next couple of years, we are going to end up with a mishmash of states where you can access abortion and states where you can't access abortion.
Mhm.
And I think that telehealth platform is going to be so important for those people who are living in those states where you can't access abortion. Now, the question will become, what's the legality of mailing the abortion pill into those states? And I don't know those answers because I'm not a lawyer, and I'm sure that will be another layer that has to be analyzed. But I think being able to mail the abortion pill is going to be incredibly important if and when Roe gets changed.
Yeah, and
Yeah.
I think we can go down. We don't have to go down that lawyer rabbit hole with law and stuff, and statewide differences between the two, because everyone's got their own opinion on that, and kind of stay objective. But for your Planned Parenthood, is abortions like? Is this? I feel like when people think of abortions, like they think there's just like a mass lineup of people like waiting outside to get this done, and just a bunch of like. I'm sure this is a huge emotional and very, I mean, a lot goes into this, right? And so is it common? Is it not common? And maybe what's your experience with that in general? Because I have no idea, to be honest with you. So I just want to get your take on it.
Yeah, yeah. So for us, in terms of revenue, it makes up about 5 to 10% of our revenue every year. So
Hmm.
it is a small portion of our revenue. We offer many other services in addition to abortion. So for a typical day in our clinic, we actually see patients for whatever they need, kind of all embedded into the same clinic. Meaning, if you're sitting in the waiting room at our clinic, you could be there for the abortion pill, you could be there for birth control, you could be there to get an STI check. It can be anything. And I would say, like, looking at a common schedule for us. So if our clinicians see 20 to 30 patients a day, there's probably 4 or 5 abortions in there, but
Hmm.
there's a lot of other stuff going on too. Um, so did that answer your question in
Yeah, it
terms
did.
of
And I was
what
going
it
to
was
ask,
like?
do you have a lot of people changing their mind? Like, do you have more people coming in and like just asking questions and more of like, I was thinking about it, but I don't know.
I think that's a great question. So I would say my answer is going to be annoying because I'm going to say it's so individual. And
Yeah.
that's how we approach it, is every single person who comes into us with a positive pregnancy test, the first question we ask is like, how is this for you? Like, tell me what
Yeah.
you're thinking. Tell me what's going through your mind right now. And we spend a lot of time training our staff how to do really good, objective, but compassionate counseling around what options folks have.
Mm.
And so we spend a lot of time, going through, like, here are the options. Continuing pregnancy is an option. Adoption is an option. And then these are your abortion options. And sometimes people say, I would say no two people are exactly alike. Some people, and I think one of the things that I like to break down is that this is a really difficult decision for everyone, because it's not.
Of
There are
course.
some people who come in and say, I know I can't be pregnant right now. This is not a possibility for whatever reason that's happening in their life. Their mind is made up. They've resolved it in their own mind, and they do it. They move on.
Yeah.
It doesn't have to be this big emotional burden. For
Do you,
some people, it is, though. Certainly, for some people who have more conflicted emotions, and probably the thing I say the most to patients is this can both be the right decision and also one that feels sad or feels like you have to mourn it a bit or makes you feel angry. Or I always joke, because the pregnancy hormone makes it feel like it's very hard to control emotions at baseline. I'm like, it can feel like all those things at the same time and still be the right decision for you.
yeah.
Um,
Do you
yeah.
have people set in place for emotional counseling there on after, or is that like, are you working with like another clinic or something?
We work with community partners for that. We don't offer counseling on site, but we do connect people with community resources. And there's actually this really fantastic organization called Breathe, and it's it is both phone and telehealth setup. And it's basically, it's both the accessing like licensed counselors and therapists, but then also being able to just talk to somebody who's gone through a similar experience, like a peer-to-peer session too. And that can be really beneficial for a lot of patients. So we connect a lot of folks with Breathe. That's a very helpful resource that we use for a lot of folks. But I also want to disavow that, like, everybody walks out of here needing counseling, because a lot of people don't. And most of the people who I feel like maybe we really want to connect with counseling, it's usually because of the context of everything happening in their life that have led to this situation where they can't be pregnant right now.
It's not one thing. It's kind of just a collaboration of different things in their life.
Exactly. And so, um, gosh, especially in this past year when we're all trying to accommodate, totally throwing our lives upside down. And, most of the people that I meet are already parents too. And they kind of know what they need to do to be a good parent and recognize, holy crap, I got to prioritize these kids that I've got right now. And sometimes that means making a really difficult decision or going through something that's personally painful, but really prioritizing those kids that you have already, and going, phew, my resources are expended with what I'm dealing with right now. And we also, I would say it's not uncommon, and I provided abortion care yesterday, and had two patients who are, in the middle of a really difficult domestic violence situation. And I would say, it's not like every abortion I do is associated with domestic violence, but that is a theme where people are going, I've got to make sure I'm safe, right? And I'm taking care of myself in order, to take the next step in life to do what I need to do.
Well, one thing you said that was interesting was that a lot of people are mothers. Is that the most common patient population that you're seeing? That usually they're already mothers who are coming in, or because when I originally thought of Planned Parenthood, it was always just like young girls who, maybe
Mhm.
something happened to them, whether
Yep.
on purpose or not. Those are the people getting the abortions. But is it mostly just parents already, or what? Maybe you can speak to that.
I would say over 90% of our patients are already parents.
Interesting.
Yep, yep. We do obviously see folks in the 15 to 19-year-old age group. Oh, gosh, I'm sorry, I can't tell you exactly what percentage of abortions are in the 15 to 19-year-old. But if we take like yesterday, for example, I think I did like 18 procedures, and I think two of them were between 15 and 19. So I would
Mm.
actually say the vast majority of people that I take care of are like 20 to 40. And I actually I did an abortion yesterday on a 42-year-old. So it just
Wow.
also goes to show, um, I do abortions on grandmothers all the time. That comes up all the time. And they're like, like, I'm a grandma, I can't do this over again. I'm not starting all over again.
Yeah.
Um,
Right.
yeah, so it really is across the board. It really is, which is to also say a lot of people are coming into abortion for very different reasons too. So, I've met a few folks who know that maybe there's something wrong with the fetus and that it's not going to turn into a healthy pregnancy down the road. And this may be very well a desired pregnancy, but it's not a healthy pregnancy. And so, I've definitely done quite a few of abortions for that indication as well. So it really is across the board. But I would say the vast, vast majority of people that I take care of are already moms. They know what they've got to do to be a good mom, and they're saying, you know what, I've got to prioritize the kids that I have right now.
And do you need parental consent for an abortion?
That's a state-based answer. So
Okay.
in New York State, no. In New York State, a pregnant person is considered an emancipated minor, so they're able to make their own medical decisions, which includes abortion and contraception care.
Okay.
That is a different answer in different states. And so I will say, for example, the answer in Ohio is no, they can't make that decision by themselves.
Hmm.
And so we see a lot of patients who drive to us from Ohio, because actually Western New York is not that far from Ohio.
Mm-mm.
Um, very far from New York City, who, for those of you who think I live close to New York City, but so we have a lot of young folks who drive from Ohio to us
Oh,
because they
interesting.
would need their parents' consent in Ohio, but in New York State, they don't.
Interesting.
Yeah.
That's
But it's also really hard to pull together cash and a car to be able to drive 2 states away to get an abortion too.
yeah,
So
monetarily
especially when
wise,
you're,
what do we look like? What is it like? I mean, I'm sure you have people who can't afford it and or are uh, tight on money or whatever. what is the situation with that? Is it insurance based? Is it, I don't understand it. So
Yeah, absolutely. So I'm sorry, in New York State,
yeah.
if you basically don't make more than like $3,500 a month, you qualify for our emergency family planning benefits program, which is part of New York State Medicaid.
Hmm.
So if you are a New York State resident and you make less than like $3,500 a month, I don't know exactly what the threshold is, but it's like pretty high, frankly. Like, a lot of people fall under that.
Yeah.
You automatically can get this emergency Medicaid program, which covers both abortion and contraception. So for folks in New York State, that is an option. Sometimes teenagers even use that emergency program when they don't want to use their parents' insurance, if that makes
Mm.
sense.
Yeah, yeah, yeah.
You can actually enroll them in this emergency Medicaid program. So no statement gets sent home saying, your son or daughter was at Planned Parenthood and they had these services done. So in New York State, for New York State residents, we are pretty darn lucky. And unless you're making like more than 80 grand a year, we can pretty much get you onto Medicaid and cover your abortion and contraception.
Interesting. And so we're talking about, no, go ahead. You want to finish the
And
thought?
then, but if you're from out of state, you do not qualify for those programs. And depending on your insurance, it may or may not cover abortion. It's plan dependent,
Mm.
insurance dependent. Sometimes that comes down to state law. Most insurance plans in places like Mississippi do not cover abortion. So if you're from out of state, you might use your insurance, you might not. And then if not, you pay out of pocket. We do have a sliding scale where we look at your income and we slide how much you owe based on your income. But it would then be an out of pocket expense, which I think is around $400 at our affiliate for the in-clinic surgical abortion procedure or a medication abortion, which if you want to talk about the differences between those two, I can give a quick summary if that's helpful. So, that's not a small chunk of change for a teenager to
No,
try
not
to,
at all.
and we
Especially
do
if you're
have
stressed
some,
and
exactly. If you're like trying to figure this all out,
yeah.
we do have some emergency funds that are through national programs, but it's a very small percentage of how we fund services.
Yeah. What is the difference? What is the difference? You already piqued my interest. What's the difference between like a surgical and non-surgical?
Absolutely. Absolutely. I think this is really important for people to know. So there are two ways to do an abortion. One is by taking a pill and being at home. So that's what I refer to as a quote medication abortion. It involves swallowing a single pill that is called mifeprex or mifepristone, because in medicine we have to have two names for everything
Of
just to
course.
confuse people. And it is basically a pill that like attaches to the progesterone receptors of the pregnancy and basically stops the pregnancy from continuing to grow. So it's not terminating anything, it's not killing anything, it's just basically stopping the pregnancy from continuing to grow. So that's step one with a medication abortion. You take that pill, mifeprex, and then you go home and we send you home with some pills that are called misoprostol or Cytotec, which some folks may have heard gets used for different reasons in medicine, but it basically causes muscle contraction. And so it causes the uterus to contract and push out that pregnancy that we stopped from growing with the mifepristone or the mifeprex initially. So it's a two-step procedure, one pill to just stop the pregnancy from growing, and then a second set of pills to basically get the uterus to push the pregnancy out,
Yeah.
which is exactly what we do for the treatment of miscarriage. So it's basically the same thing we would do for a miscarriage. It's just we're kind of giving that first pill to essentially create the miscarriage by stopping the pregnancy from growing.
Gotcha.
That's option one. I just want to add in here that that's incredibly safe. We have over 20 years of data of medication abortion in the United States, and the rates of complication for medication abortion are around 1%. So when we're talking about like Complications that would mean you got to go to a hospital, you really need some follow-up care, is about 1%. So it's incredibly safe. And the way I always explain this to people is like, it's basically a miscarriage, and miscarriages happen all the time. 1 in 3 pregnancies end up in miscarriage. And that's essentially the process that we're creating with medication abortion. So that's medication. You receive the pill here in clinic, but then go past the pregnancy at home. A lot of people like that option because they don't really love medical settings. And there is this kind of feeling of like, it's a little bit more natural. I'm in the safety of my own home. I get to just pass this pregnancy. So for some people, that feels like the better option. The other option is to have an abortion procedure in clinic. It's a very short procedure, usually takes between 5 to 10 minutes at most. And it's a 3-step procedure where we sort of prepare the cervix. We then dilate the cervix or open the cervix slightly. We put a straw through the cervix that goes up into the uterus, and then usually using a really gentle handheld suction. It's not a machine, it's just a manual suction that I create in my hand. We gently remove the contents of the uterus, and that's the whole procedure. And then patients sit with us for usually between 15 to 30 minutes in the recovery room after their procedure, and then they go home. And again, complication rates for that procedure are very low, usually between 1 and 2%. The most common things are, infection or heavy bleeding, but really the vast majority of folks do really, really well. We also do offer some sedation for folks who have that done in clinic. So whether we just give them some oral sedation with a little Valium and Vicodin, or we do offer IV sedation too with fentanyl and Versed, that's helpful to some people. And some folks, the nice thing about having it done in clinic is it's 5 to 10 minutes and then you're done with the whole thing, as opposed to, having to go home and pass the pregnancy and wait for the uterus to push it out. So, it really just, people always say to me, what's the better option? And I say, there's not a better option. It really comes down to just which one sounds less annoying to you.
Yeah. And then what time frame wise, what is the cutoff where we're kind of like, this is too late? Or
yeah, you're gonna love me by the end of this. That's a state-based answer.
I was like, she's gonna say it's a state-based answer, but I'm gonna ask it anyway.
But in our practice here in New York State, it's very clear that we can do abortion procedures until viability of the fetus, and then maybe even past that with fetal anomalies, where we know that will not be a viable fetus when it comes out. At our practice here at Planned Parenthood of Central and Western New York, we provide abortion care through the end of the first trimester, so through 13 weeks and 6 days. So that's what we offer currently. It is safe to do medication abortion, so that home procedure, it's safe to do that up to 11 weeks of pregnancy. So that's like 2.5 months of pregnancy. Past 11 weeks, we recommend the in-clinic procedure.
Gotcha. And we've been talking all about like post-pregnancy and everything. What about, I think what we need to get back into is preventative care and so forth. And so, obviously, I'm assuming most of your patient population demographic is females or females in that sense, and maybe not, but this is my assumption from not knowing anything, right?
I love it.
And so I want to ask, what is the majority of patients that you see? Do you see like males or mostly females and so forth? And then maybe we can go into other stuff after that.
Yeah, it is definitely not all females here, but certainly a bit more shifted in that direction. I think the last time I looked at it, our visits were between 70 and 74% people who identify as female. And then probably like 25 to 30% male. But then we also, do our gender affirming hormone care visits where people may identify as gender diverse, gender non-binary, or we have, trans men and trans women as well. So we do all of it. And I think that's like a huge misconception across the board, is that like Planned Parenthood is for women only.
Yeah.
We see a lot of men in our clinic who come in for STI screening, want to talk about ways to have safe sex. And then I think as we've gotten more into safe sex with PrEP as well, so taking a pill to make sure that you're preventing the transmission of HIV, that has brought more men into our clinics as well to be able to access those services.
Interesting. And then for prevention of pregnancy, right? You said you provide education.
Mm-hmm.
what is, I'm thinking immediately like birth control, right?
Yeah.
And what is your determining factor of when to prescribe birth control pills versus just safe sex education? Because I've known, people who have had, they don't like the pill, or,
Mhm.
they had like weird reactions with it and so forth. So like, what is your kind of determining factor? Are you always going to the pill, or like, what's your mindset with that?
Oh, I love it. So couple of things. First of all, the pill is definitely not my favorite birth control.
Yeah.
My favorite birth control on a personal and also like global level are IUDs. And the reason why I like IUDs is because you put them in once and they work for years, and they don't require somebody to remember to take a pill every day, which, let's be honest, that's just hard to do. I love it when they've done studies of men taking antibiotics twice a day for 2 weeks. Like less than 50% of men do that. So we expect women to take a pill once a day for their entire reproductive life, which is like over 20 years, never once mess up. It's crazy. It's
Yeah.
it's totally crazy, right? Especially when like a lot of times they have side effects to those pills. You may not be eager to take it. So what I like about those long-term methods is I call them the set it and forget it methods. You just get to put it in once and it's working for you. So on a personal level, I love those methods. My answer though, as a doc, is the best method for the patient is the one that I have that they're buying into.
Mm.
So my goal in talking about contraception and doing contraceptive counseling is to get to the best answer for that patient, which
Mm.
is different for every single person. So the way I start talking about birth control, which I did this all day yesterday, the way I open this conversation is, tell me what birth control you've tried before and what you liked about it or what you hated about it. And so then when they say, on this method, I had these reactions, and on this method, I had these reactions, I take all that information and say, then I think this might be a good answer for you. So it's very individualized. So I don't think there's like a perfect birth control for everyone. I think the perfect birth control is the one that you kind of look at all the options and go, this one maybe seems like the least of all evils, right? Because I mean, there's kind of like some annoying side effects to almost everyone. And what I say to women is like, I'm also here to just like walk with you through this journey. Let's try pills. If you hate them, if you have negative reactions to them, come back to me. We'll go back to the menu. We'll keep trying stuff together and hopefully find one that lands well for you.
Mm.
Um, as far as, you know, practicing safe sex versus being on birth control, um, I used to be a bit more paternalistic about this, like you must be on birth control. And then I realized like they were going to go home and probably just not take their pills. They're probably going to say to me, oh, sure, Dr. Potter, I'll take those pills because you basically just forced me to do it. Right.
Right.
But like, are they buying in? Are they actually using the method at home? Who knows? So in terms of talking about this, again, I come back, and this is kind of that technique I was talking about earlier around behavior change, but I really come back to the idea of motivational interviewing. Have you heard that term before?
Emotional
Um,
interviewing.
Motivational
Oh,
interviewing.
no, 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 no.
And it's cool. It was originally created by, I think, social workers and therapists, but it's kind of this idea of, in any type of counseling conversation, how do I as the healthcare practitioner not give you the answer,
Yeah.
but help you to identify the best answer for you, right? And so that's how I approach these conversations with patients. So, if somebody is sexually active, I'm kind of flipping the conversation back to them and saying, how would you feel about getting pregnant right now? Oh, you definitely don't want to be pregnant? That would ruin your life? Okay. What do you think about ways to not be pregnant? So I'm really like flipping it back on the patient. And they go, well, on pills, I had all these terrible reactions and I didn't like it. And on Depo, I bled all the time. And, I had the one that went in my arm and I hated it. Okay, cool. So I'm hearing not this one. I'm hearing not this one. I'm hearing this side effect to this one. So what about this one? What do you think about that? And here's why I'm suggesting this one, because you told me all this information here. So I'm kind of taking what the patient is telling me they need and want, and then trying to kind of use my expertise to go, okay, these are all of our options on the menu. But then in my response, also being like, what do you think about this? What would be the good about this? What would be the bad? Um, and are you willing to give it a shot? And that's I think has led to better success for me in getting patients to the right method for them, is to also say, this is a trial. Like, come back to me in 6 weeks. If you hate it, we're going to pick something else, and we're just
Yeah.
going to try and stuff together.
And I think it motivates the patient, right? Because it's not like they're coming to you and you're providing the answer. They're almost giving you the answer, and they're like, they feel like they're in control of their own care, which I try to do a lot, as much as I can, with a patient. And sometimes I don't ask this question, but like, what do you, as a physical therapist, what do you believe you have to do to get better? And sometimes the answer is just as short as like, well, I don't know, I called you. And
Right.
so but sometimes they're like, oh, I don't know, I have to do like some stretches, or I have to do this and that. And so, or I have to do some kind of a massage or something like that. That kind of tells me what their preconceived beliefs are for getting better, right? And so with all my knowledge, I'd be like, okay, if they like massage, or if they like hands-on treatment, I can do that, and then like slowly graduate them to exercise. But then some people are like, oh, I'm gonna have to do some exercise and get better. I'm like, okay, perfect, we're on the same, like this. Yeah, great, awesome.
I
Like,
can dive in with you and go straight there.
yeah,
Yeah.
yeah, 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 yeah. So that, I think, and that needs to be done more with patients, is just giving them, making sure that they feel like they're making the choice to do and be a part of their own care, rather than like the doctor being like, just do that, go home.
Exactly. Exactly. I also have to say, on a personal level, it's led to more satisfaction for me.
Mhm.
In my first few years of practice, I felt all this pressure to like create the answers that would help these people to change their lives, and then inevitably failed and failed and failed, because I'd be like, well, here's what works for me for exercise, right? But I'm different than this person. And so I think I felt like really burned out. I was like, I'm giving people, I'm telling them 150 minutes of exercise every week, do it. And nothing's happening. And I felt bad about myself, like I'm not being a good doc for these people. And so it also, I, I always, it's kind of like taking the burden off of me too,
Mm,
to feel like I have to create the answer for them. I more now conceptualize myself, it's a little hippy dippy, as like their wise guide, right? Like I'm
yeah.
just trying to guide them to the answers that I hope will work for them.
Yeah, I don't know if it's the same for you, but I always felt like I needed to hit a home run every time I had a patient. Like
Yes.
I have to, like, this has got to work every single time. Like every
Yes.
single treatment's got to be perfect. They're going to, I don't care how unique you are, it's going to be great. And every time I just get hit in the face, like with a sucker punch, like, nope, this isn't working, man. And you're like, oh God, come
Because
on.
they're like, I don't want to do these at home by myself. Yeah, yeah.
Exactly. Yeah. So no, I think that's excellent. So back to kind of like the, do you guys hold classes in regards to like sex education? Because I know for me, I grew up in a very small town, and we didn't really have, like, our sex education was like, this is a male, this is a female, and good luck. Like, it wasn't like it
Have fun
wasn't
this weekend. Yeah.
exactly, there really wasn't anything there. And so I can only imagine in states that aren't allowing Planned Parenthood, or even like, as you guys are trying to become like a sex education place like Mississippi, or we don't mean to bash Mississippi, but
We can bring Alabama and Arkansas into the mix too.
yeah,
Fine.
wherever
Texas
wherever
too.
you are,
Yeah.
wherever you are, what are the resources that you can access, just for if you want to know? And like, are you guys trying to like intertwine yourself into the community schools, and so people can know more about it?
Yeah, that's one of my favorite things about working for Planned Parenthood specifically, is I always say it's actually like it really has three prongs. And obviously the one that people know the best is the medical services, right? We have our bricks and mortar clinics where people show up and get medical care. But then there are sort of two equally important arms to Planned Parenthood, and one is our political and legal advocacy. So, having our big political arms in DC that essentially do lobbying, like lobbyists, to our congressional delegates and to the presidency, to basically say, like, these are services that we need. This is funding that we need on a national level. And then, and part of that kind of dovetails into the third arm, which is education. And that, at each individual Planned Parenthood, there's a health services department, and then there's always an education department as well. What that education department looks like is very different, not just state to state, but also affiliate to affiliate, depending on their inroads into the community. So actually, our Planned Parenthood provides almost all of the sexual health classes in the Buffalo City School District. So we
Oh
are
wow.
And that's just like a historical contract that has been there for many, many years. But we show up, our educators, so they're not our health center staff. They're not ever providing care directly. They are truly educators. Some of them are teachers. They go out into the schools and they do sex education. And then in Buffalo, it's really cool. We actually have a mobile unit, so an old restored van that has 2 exam rooms in it, and they park across the street from the high school, and then kids go across the street and get their birth control at the end of the day. So it's really, really awesome. It's obviously been harder to access our kids, and we've really seen services go down in the past year with COVID. Buffalo City School District was remote for almost all of last year.
Mm.
So that's really made it challenging for us to connect with kids. And I'll be honest, we see the STI rates and the teen pregnancy rates go up as what I would conclude a direct result of lack of education and lack of presence in the schools and connecting with those kids in the past year. When you look at the national data, comparing like our area compared to places really in the South, you can pretty much see a direct correlation between sex education and STI and teen pregnancy rates. So the less sex education in the schools, the higher those rates are. And then nationally, when you look at the states where there's better comprehensive sex education mandates statewide, those teen pregnancy and STI rates really drop. And so, one of my life great frustrations is watching policies and legislation that get enacted that are in direct opposition to clear fact-based data that we have, and seeing those decisions being made for sometimes whether it's beliefs or religion, decisions being made based on that instead of on data. Like, the more we talk about healthy, safe sex in schools, the more healthy, safe sex our kids have.
Yeah.
But when we stop talking about it, there are repercussions, and abstinence-only education does not work. So,
Yeah, and I think you put on a good point with and it's got to be incredibly difficult with religion and beliefs and things of that nature, and them being so tightly knit to what you do. You must get some flack for what you do a lot of the time. And you said, we talked before, and you mentioned you have a lot of people always outside your clinic. Is that true?
Yep.
Yeah.
So we pretty much, I'm usually at our Rochester clinic because that's where I live. I'm based out of Rochester, though I certainly go to our Buffalo and Syracuse clinics a lot too. But I would say we have, a handful to a dozen protesters at most of our sites every day. They have signs up, they bring megaphones, they, at this point, they pretty much know our staff. And so when you get out of your car as a staff person, they like to say things like, we can find you a better job, you can have a better life. There's a couple of websites, one's called abortionworker.com, and it's all about trying to, like, if you work in abortion, we can get you a better job. Which is just, it's a layer to add to work, right? It's a layer to come into work and be challenged as you're like literally crossing into the parking lot. We often joke.
You're just sitting in your car like, okay, let's do this.
Exactly. And, after many years of doing this, to be very honest, I'm pretty good at tuning out what they say to me. Like, I'm just like, I don't care. I'm not going to listen to you. But what still is painful for me is when I see a patient and they say, isn't there anything you guys can do about those protesters out there? I took the bus and I had to walk past them and have them tell me I'm going to hell, or, have them tell me I'm a terrible person. And this might be somebody who's really struggling with their decision, but has to make this decision for whatever reason in their life. And, what pains my heart is seeing the negative impact for my patients. At this point, personally, like, I've steeled my heart, I can deal with it. But it really hurts me to see that, especially young patients who are very impressionable and influential. And they're just like, Dr. Potter, why are they out there? Like, why do they care so much to come and yell at me today? Like, I'm devastated. I'm crying. I'm struggling with this decision. Like, why are they doing that? And I don't have a good answer for that.
Yeah.
And I will say, I used to just be like, bah, I tune them out. It's been harder in the past year. It's been harder to hear about healthcare heroes in the news every single day, and then still show up and have people tell us we're going to hell and that we're bad people.
Yeah.
I think that's added like an emotional burden to this past year. And then also coincidentally, most of our protesters are like anti-maskers. So there's like that whole level too, where I feel like there's also been some like putting our community at risk by showing up in groups as the pandemic has been happening. So I will say I've been a bit more agitated in the past year than I was in like the 5 years preceding that, where I was just like, they can do what they want. They
Right.
can say to me what they want. So
Yeah, and another one of those hot topic, and not just abortions, but also you had mentioned you deal with gender reassignment and so forth, and so I think we can maybe talk about that and go into. Have the numbers changed? I think that's a good place to start. Have you seen more as over the past like 5 years as it becomes more, I mean, relatively socially more acceptable, or have the numbers always been the way that they are? And there's just been a lot of like people don't know about this issue, and maybe we could talk more about that.
yeah, absolutely. So if you don't mind, I'll offer a little language suggestion for you too. We don't use gender reassignment to talk about the hormone care that we provide at our facilities. And there is some stigma within the trans community about using the term gender reassignment. So what we talk about is gender affirming care. So I just
Oh,
wanted to
okay.
share that with you.
Yeah, I don't know.
Um,
So
yeah,
learning a lot. I'm
exactly.
learning a lot today. So
Yeah, exactly. And I think, you know, my biggest suggestion to folks who are maybe, talking about trans care for the first time or talking about trans folks is first of all to recognize like we're all going to make mistakes. I am a cisgendered person. I am not a trans person, and I make mistakes all the time. And so I think being open to just being like, whoops, I made a mistake. Thank you for that suggestion. I'll make that change, and then just kind of move on too. So I have also learned a lot in the past 5 to 6 years. And what I would say too about trans and non-binary care is as it is becoming more acceptable to talk about, the language evolves, and it's a moving target. So maybe the language we talk about today in a year or two will not still be the language that's used. I find it's a rapidly moving space. So I would say these folks have always been there, always. They just have not been able to access safe care before. So there are some really impressive statistics around trans folks, trans and non-binary folks, not just reporting like poor care in medicine, but reporting actual like harmful or traumatic care. I have a handful of trans folks in my social circle, and I can't tell you the number of just horrific stories I've heard about the type of care that they receive when they go to places like a hospital. So for instance, I have a friend who's a trans woman, um, and I'm sorry. Well, I'll tell a different story. I'll tell a different story because this is
okay.
it's a better synopsis. So I have a friend who is a trans man. So, you
So
know,
before we move on, can you describe that because someone may not know?
yeah, absolutely. Absolutely. So trans refers to somebody who, whose gender identity, who they are on the inside and who they identify as is a different gender than basically the parts that they were born with. So we sometimes use the term assigned female at birth or assigned male at birth, and that's kind of your sex assigned at birth or the designation that you were given. And so trans folks identify as not that. And so maybe in their case, their external genitalia does not match their internal concept of their own gender.
And so when you
Um,
say trans man, it's you can
Somebody
describe.
who is assigned female at birth,
Okay,
but then identifies as a man.
gotcha.
So maybe their external parts might look female to us, but their gender identity is male.
Okay,
And then on the flip side, if you're a trans woman, you're assigned a male sex at birth, and may have what we would say are male parts, but your gender identity is female.
gotcha. So you
And
have your
then,
friend who's a trans man.
yeah, and then a term that you may hear thrown around is gender dysphoria. And that means basically like the ickiness and malaise and terribleness that people feel when they have to exist in a body that does not feel like the right gender, right? So if
Mm.
you were assigned male at birth, you have male parts, but your identity is female, gender dysphoria is that horribleness, ickiness that you feel having to exist in a body that does not feel like the right gender to you, or
Okay.
is not the right gender. Not that it feels like the wrong gender, it is not the right gender for you. So I have a friend who is a trans man and has been on hormones for many years. So honestly, if he walked into this room right now, you'd say, "Yep, he's a dude," right? And so he had an issue with recurrent UTIs, or urinary tract infections, and so went to the emergency department and said, "I think I have a UTI. I get them all the time." And the doctor just repeatedly kept saying, "Oh, this is so weird. We don't," because UTIs are much more common in people with female parts. And that's because the female urethra is much smaller than the male urethra. So it's easier for bacteria to climb up and cause an infection. It's a shorter climb, so it's easier to happen. And so the doctor came in and said, "Oh, this is so rare. We don't see recurrent UTIs in men. And, this is so weird." Brought residents, brought medical students into the room. And the whole time my friend is trying to go, "You know what? You're mistaken. Like I'm a trans man. I have female parts. So this isn't so weird, right? Like I have,
Yeah.
you know, tried to interrupt, tried to tell." This doctor came back with residents, with medical students, and basically said, "We'd like to do an exam now," and like exposed my friend's genitalia and was like, "Whoa, what's this?" I mean, how
Jesus.
awful, right? Exactly. How awful. So let me tell you, that friend will not go to emergency departments anymore. Like,
Yeah.
they were exposed in front of a crowd and made to feel incredibly embarrassed. And this is something that they experienced dysphoria around at baseline. So to sort of have this pointed out, to have this horrible experience, it's bad, right? Like, that makes those folks not want to come back to care, right? So I've heard this type of story many, many times from trans men. So a lot of trans men end up being like, "I know I have a UTI, but I do not want to go get stigmatized care. So I'm going to just try to like deal with it. I'm going to drink a lot of water. I'm going to drink cranberry juice." And then maybe end up with a worse infection, like a kidney infection. And that's the exact pattern that I see for a lot of trans or gender diverse folks, is that because of the stigma and harm that they've experienced in traditional medical settings, they're just not going to go anymore. They're just going to avoid the care at baseline. And I think that's really problematic, because we know outcomes are worse when people don't get basic preventive care, which kind of comes back to, ways to take happy, healthy care of yourself, whether it's your sex life or just, taking good care of your body. Cancer screenings are, the percentage of trans folks who get their routine cancer screenings, whether it's cervical cancer or colorectal cancer screenings, are much, much, much lower because they just don't want to come into these spaces at baseline because maybe they got, exposed in a very embarrassing way at their last appointment. Another common story that I hear from trans folks is, people coming out into the waiting room and using their dead name. So their name that they were assigned previously, but that they don't use anymore.
Mm.
So, getting outed with their dead name. That's another common story that I hear of, just ways that they don't feel comfortable in these spaces. And the issue is often the name that they use is not in accordance with the name on their insurance card. And it's amazing how in medicine, we're not very flexible about those types of things. And so, people will always defer to the name on your insurance card, even if that's not maybe the name that you use in day-to-day life. So I wanted to take a moment too to talk about one other term I've been using, which is non-binary. So, we think often of gender as being on a spectrum of male or female. And when we talk about, trans men, those are people who are maybe assigned female sex parts at birth, but identify as male. That's still on that very like dyad spectrum of male and female. Whether you're a trans man or a trans woman, you're still on that very dyad spectrum. And non-binary refers to folks who identify somewhere in between or fluidly. There are also people who identify as gender fluid, meaning maybe their gender identity is not the same from day to day, or maybe they just land somewhere on that spectrum that's not fully male or fully female, but somewhere in between. So I have quite a few patients for whom we do low dose hormone therapy. So they're not trying to get to all the way on the other end of that extreme, but they're trying to end up somewhere kind of in the middle.
And for hormone replacement, when do you, well, I'm trying to think the best place to start for
Yeah,
when is the earliest that you can start to decide that you would want to get
yeah,
if you were feeling that you were you had this dysmorphia or what was it?
yeah.
Was dysmorphia and you
Dysphoria.
dysphoria and
Hmm.
we're unsure
Yeah,
of how to go about taking the next steps. How old do you have to be, and when do
yeah.
you need parental consent versus not?
Yeah. So at our affiliate, so the clinics that I oversee, we provide hormone care to adults only, so 18 years old and up. Um, there are options for initiating um, gender modification earlier in life, much earlier, and that can be done. So when you're into adulthood, oftentimes we are working with people who we are always working with people who've already gone through puberty, right? And so we are sort of adding hormones to move the gender in a different direction, but folks have already gone through puberty. And let me tell you, it's amazing. We have folks all over the age spectrum. I did a gender affirming hormone care clinic a couple of weeks ago, and I saw some kids in their 20s. I saw multiple people who were starting hormones over the age of 60. And I mean, these visits, I mean, I could almost cry recounting some of these visits because these are folks who are literally saying to me, like, this is the best day of my life, and I'm 66 years old. I've been living in a body that does not feel like my own for over 60 years. And I mean, it's just like goosebump inducing. They're so happy, they're so validated. It's really cool. And it's been very cool too to see them have a lot of support from families. These are maybe people who've been in traditional marriages with children for 20, 30, 40 years. And their families are like, we've always kind of known, right? Like
Hmm.
there's always been these indications that maybe my dad is a trans woman, and to see their family come and support them to make these transitions in their older age, it's so cool, and really rewarding care to get to like help people live their best lives. So I tangented from kids, which is to say I mostly deal with adults.
Okay.
But there are options for initiating hormones in kids too, so people under age 18. And actually the options are more plentiful because you can do both hormones to change gender or to change the gender spectrum when that is using principally estrogen and testosterone. But in kids, there are also the options to use what are called puberty blockers. So they just basically, so if you were born with male parts but identify as female, they would like block the testosterone and actually prevent the testosterone from creating all of those changes of puberty. So for a lot of kids who go through puberty and are trans, it's an incredibly dysphoric time for them. They're starting to develop all of these secondary sex characteristics, a deeper voice, facial hair growth that make them feel awful, right? Like it
Hmm.
makes them feel like I'm living in this body that is not my own, that is not my internal concept of what my gender is. And so it can be a really dysphoric time. I'm going to pull it up here in a second. I have some stats around the percentage of kids who experience both depression and anxiety, but also suicide attempts. So 56% of youth who identify as transgender report thinking about suicide at some point, and 31% reported a previous suicide attempt. In comparison, for cis kids, so people who were born with certain parts and then their internal concept of gender matches those external parts. So comparatively, for thinking about suicide, only 20% of cisgender kids had. So thinking about for trans was 56%, and then for cisgender kids was only 20%. And then actual suicide attempts was 31% for trans kids and only 11% for cisgendered kids. So I think that really speaks to like, as you're going through this, whew, hormones and puberty are tough no matter what, But as you're going through this process and literally developing characteristics that make you not feel safe in your own body, we see those, rates of suicidality, depression, and anxiety really rapidly increase. So for kids who identify as transgender before they go through puberty, you can actually prevent all of that from happening. And then down the road, initiate the hormones to advance them into the gender that they are.
And is there a point of um, going back? Let's just say you have a woman who, or a person who was born with female parts and wants to become a male, and then maybe later on they want to stop when they become 21 or 22. Is there a point of like, well, we kind of did this thing already, so
You know, I am going to not answer that question because I don't provide pediatric trans care.
okay,
And so I don't want to say the wrong thing because I
sure,
don't know exactly. What I do know for sure is that stopping puberty does nothing. Like you're literally just putting it on hold. So if down the road you hit age 18 and you're like, just kidding, maybe I was born with male parts, I identified as female, but I am now here and I think I actually identify as male now, you would just stop the puberty blockers and allow the body to go through puberty and they would end up with male secondary characteristics like
understood.
facial hair growth and a deeper voice. What I can't answer is if you're a kiddo who's had puberty blockers and then already had hormones started, what is not reversible. I don't
Mm.
know that off the top of my head, and I don't want to say the wrong thing. What we talk about for adults is that often hair growth can be somewhat reversible and not reversible. It's very person to person dependent. So if you're started on testosterone and develop a lot of facial hair growth and you stop testosterone, some of that will regress, but maybe not quite all of it. A lot of what we see when starting estrogen and testosterone is a redistribution of fat. So women tend to distribute fat in different places than male bodies do. That is very reversible. We really see that shift back if people stop hormones. And then sometimes when people start testosterone, voice changes may not be entirely reversible. So if the voice deepens on testosterone, but then testosterone is stopped, sometimes that does not revert back. So we really like to counsel people around that so they're aware of that before they initiate the changes. And then lastly, fertility is like totally up in the air in terms of data. I both say to trans men who are, maybe born with female parts, but initiating hormones to become men, I both cannot guarantee that their periods will stop and they won't be getting pregnant. So I can't guarantee that it will prevent pregnancy or stop your period. And I also can't guarantee that if you stop the testosterone down the road, that you'll definitely be able to get pregnant. So it's
Mm.
kind of like, I can guarantee nothing about what's going to happen with your ovaries and uterus.
Yeah, so it's kind of a mixed bag depending on who they are and everything. Do you have people who
Yeah.
are kind? You said you had mentioned before. There's people who are kind of they're gender fluid and they can change from day to day. Do you get people who are like really trying to flip flop a lot, or no? Okay, I just figured I'd ask.
Very, very rarely. Very,
Okay.
yeah, no, no. And I often find that the folks I've met who identify really as gender fluid, um, I have never initiated them on hormones because they don't want that permanency of
Mm.
hormones. The few folks who I have had in my practice in recent memory spend more time on physical appearance and expressions, like maybe the type of outfit that they're wearing, or whether they wear makeup or not, or how they wear their hair is kind of how they express their gender fluidity, that physical expression, and are less likely to want to be on hormones because they don't really want that permanency of the hormones, if that
Gotcha.
makes sense.
Yeah. No, it does. And for I know I worked at Kaiser when I was here for a brief period of time, and they when I pull up the medical record, it always shows their original name, and then it shows like prefers to be called by.
Yeah.
I guess can there be confusion when you maybe go into a hospital? Because like with that guy, obviously, like we're lifting up the skirt and just trying to figure that out. Like that's very aggressive. But I'm thinking in terms of just like medical difficulties. Do you like say you get in a car accident and somebody doesn't know, and then running through the whole gamut of trying to figure somebody out? Do you think that poses an issue at all, or no?
I don't think um, I think the potential benefits outweigh the potential risks, if
Okay.
that makes sense. Like, I can't think of any scenario where we like really need to know your gender that much to tailor your medical care, other than maybe on the labor and delivery floor,
Right.
which is unlikely to be that like emergent, like, oh my God, we need to know situation, right? I can think of very few reasons where I like need to know gender. Now, there are definitely some things out there, like, I'm sure a trauma urologist right now would say to me, well, it's very important that I know what the internal structures are, right? Yeah.
Yeah.
And so certainly there are probably some very specific situations, but I think what I'm trying to say is that risk is so low. Like,
Yeah.
the risk that that situation is going to happen is so small compared to the risk of depression, anxiety, suicidality of having to exist every single day in a body that does not feel like your own.
Gotcha.
Um, and so that's where, I often have these conversations with colleagues. So whether I'm talking to somebody's primary care doc or their urologist or their nephrologist, their kidney doctor, and they say, but they have these risk factors. And I'm like, yeah, they've got those risk factors. But there's also a ton of risk factors of forcing them to live in a gender that they do not identify with, that makes them feel dysphoric in their body every single day, every single minute. There is risk to that too, right? And so that's that gray area of medicine where we have to say, well, what's the potential benefit versus the potential risk? And almost always, I see the potential benefit of allowing someone to exist as their authentic self. For me, almost always outweighs the slightly increased risk of stroke or heart attack in the long term. And I also kind of feel like that's their call to make, right?
Right.
Like, what's worse for them? The increased, a 1% increased risk of heart attack, or having to live in a life that doesn't feel right to them. So I kind of, and that's where I love taking care of adults, is I can sit and have an informed consent discussion with them and say, you do have high cholesterol. I think that puts you at a higher risk if we put you on estrogen of things like stroke and heart attack. What's interesting, and you'll love this, is both anecdotally and in studies, it is freaking amazing the amount of consistent like weight loss and self-care that we see happening in folks who transition. So maybe
Hmm.
it's somebody who's been living in a female body their whole life but identifies as a trans man. When they get to live their life as a trans man, they're finally like proud of their body, interested in their body, not like feeling repulsed by their body. And it's so interesting. There's kind of this little like community of people too who are like, then they get like really into taking care of their body. They're interested in exercise. They're interested in lifting weights, in like making this body
The one that they
something
want.
they want. Exactly. And so it's kind of cool. Like, I've actually seen, we've had quite a few patients with like pre-diabetes or, very like medication treated diabetes. So not severe diabetes, who get off meds, don't have pre-diabetes anymore because they're suddenly like existing in a body that they don't feel repulsed by all the time or
Interesting.
don't hate, or so it's really cool. I've
Yeah, I would have
been
never thought of that. That they feel because they feel that way, and the dysmorphia is kind of not gone, but under control. That they would want to live in a body that, like, I want to take care of this one because I actually enjoy it, and I want to exercise and do all that and eat better
I
and so
feel
forth.
proud of this body and it feels like me. So I
Mm.
want to take care of it. Absolutely. Absolutely. Yeah. We also have seen like it's been a real opportunity, starting estrogen, does increase baseline risk of things like stroke and heart attack. So it's also this like amazing chance to say, let's talk about you stopping smoking, right? Like, that's the other risk factor that we know increases your risk of stroke and heart attack. I do not want to deny you this estrogen because it's going to make you feel like you. How do we get you to stop smoking? And it's, I've seen a lot of success with that too. It's this opportunity.
Do you deny people who maybe have diabetes already, smoking, poor health habits, and if prescribing the estrogen may lead to more? Is there a time where you're like, maybe you got to lose some weight or get rid of some other stuff first?
I typically, if I'm really, really worried about their cardiovascular risk, which you did a good job of summarizing, someone who I might be a bit more worried about, multiple cardiovascular risk factors. Let's say they have high blood pressure, high cholesterol, and prediabetes or diabetes, and smoke cigarettes. So usually for those folks, I approach it stepwise, and I recommend initiating estrogen with a patch, which the formulation that's absorbed by patch is less thrombophilic. So it increases your risk of stroke and heart attack less than the oral formulations or the injectable formulations. So I usually kind of use those as a carrot. Like, I'll start you on estrogen today on patch, but in order to get oral or injectable, let's talk about getting off of cigarettes, right? Like,
Right.
how do we
Yeah.
help you to not smoke anymore? And I use that as kind of like almost like a motivation, and it's
Like if
never
you really
like an.
want this, this is something that you're going to do and actively like participate in.
And I always frame it around my number one priority is your safety, right? Like, I want to help you be living in a body that you feel better in, but I also want to make sure we're keeping you safe along the way. I have only rejected, like flat out said, we cannot provide care for you for like 2 people. And they had like very complex endocrine issues going on. And unfortunately, our hormones are linked to our endocrine system. So for those folks, I was like, we got to get an endocrinologist involved because you've got other endocrine issues going on and
Yeah.
they're intertwined, but not. And so I said, we need an expert involved here. But most of the time, the folks with cardiovascular risk factors, I feel like we're able to meet them where they're at and then engage with them and help them to take better care of themselves. I love that part of this care. Like, it's really cool to see that. And I feel like I see more progress in this patient population than I do in my regular primary care. It's like they're motivated. They want to do this. They're excited.
Well, you
So
can
it's kind of
clearly
cool.
tell that you're very motivated and very passionate about what you do, and it's very admirable. And you don't always see that. And so, what else are you doing in regards to like legislation? Because I know you said that you're really up on the front lines and you're really like for social justice. So, like, what are you doing actively right now?
Yeah, great question. So I kind of went off on a tangent about this earlier. One of the things that I am like frequently engaged with, that is very state-based, but I'd like to share it with you, is there is a bill being put forth to our state legislature in New York State for what's called the New York State Health Act. And it would be universal coverage for all New Yorkers, similar to the universal coverage that exists in the state of Massachusetts. So it would be a state-based universal coverage system. So I've been very involved in advocating for that, because I truly believe that having uninsured folks is not helpful to our overarching system. It increased costs and it leads to poorer care and worse outcomes for those patients. So I both see it as not good for the patients and also not good for our society and our communities, which end up, it's like there is no free lunch, right? Like, that is getting paid by someone somewhere. So I think universal coverage is very important. And that speaks to building health in our communities. And then, right now, unfortunately, there was some, upsetting news this week that the Supreme Court agreed to hear a case out of Mississippi. I'm forgetting the case name right now. I'm so sorry. Around a 15-week abortion ban. And so I do think when the Supreme Court hears this case later this year, it is possible that it could lead to some big changes for Roe v. Wade. And so I am sort of engaging on educating folks around that, making sure people really understand, what does this mean? It doesn't mean that all of a sudden abortion's illegal in our country, but it does mean that it reverts to your state-based law. So maybe actually engaging your state legislatures is more important right now than trying to fix the Supreme Court, because
Mm.
it's 6-3, it's over. We're not going to change that for a few years. So don't even go there. So let's go back to our states and really try to protect women's health on a state-based level. And then thirdly, right now, because it's been in the news a lot and because there are not a lot of providers who provide trans care, I'm getting tapped to advocate and speak out for trans student athletes,
Mm.
which is a really interesting area of conversation. And what I keep coming back to is that high school athletics should be about building healthy communities and good health habits in our youth. And so I don't think we should ever do anything that discourages our youth from engaging in sports participation. And as we talked about, a lot of our trans youth have actually had puberty blockade. So there's this whole misconception around they've gone through puberty in this opposite gender. Most of these kids have not even gone through puberty. They've had it blockaded. So really advocating for the mental health benefits of allowing kids to engage in sports. And also just really trying to, I guess the overarching theme here is pushing back when I feel like politicians are entering our exam rooms,
Mm.
coming into our exam rooms and saying, you cannot provide that care. Like, I'm not interested in politicians telling me that. My job as a physician is to be looking at evidence, to be looking at protocols, to be looking at what we call gold standards of care, right? Like, what is the best care for a patient based on evidence and trial data? And that's what I want to guide my decision-making process between me and a patient, is that, and not what a legislature thinks is the right or the wrong thing to do. I want to make decisions in the exam room based on medical facts, not on policy and on feelings. So finding ways to push back. And that happens, I find it's interesting. There's so much overlap between trans care and abortion care, right? So
Yeah.
that's a feeling I've had for years, is like, you don't get to step in my exam room and tell me how I can talk to women about pregnancy. You also can't step into my exam room and tell me how to treat this young trans child.
Well,
I'm going to make
healthcare should be personal. I mean, just as simple as that. I mean, there's no reason for someone to come in and
right.
tell you what decision you should and should not make. Unless it's to the benefit or to the maliciousness to somebody else. I mean, it's between you and your doctor and whatever relationship you have with your other healthcare providers.
Exactly.
Yeah.
Yeah, 100%. It's tough. It's tough to be like, I went to medical school for a very long time. I spent a lot of money on this. We talked about this, and so it's frustrating to sort of have your expertise usurped by isms, right? By people who have strong feelings in one direction or
Well,
another.
with all that frustration, are you exercising yourself, staying fit?
Yes, I'm so glad. So yes, exercise is totally my antidote to stress. Though I have sort of a short attention span around all exercise. So I'm not one of those people who's like, I get up and I do the same thing every day. My week is like pretty diverse. I tend to run usually like 2 to 4 days per week, depending on how I'm feeling that week. And I'm not a very high mileage runner. I run like 10 to 15 miles a week at most. And I usually run, 2 to 5 miles at a time. I'm not like a super long distance runner, but I really like it. And the thing I love about running is that I can literally like throw my shoes in my car, and no matter where I go work that day, if I'm at a different site or I'm in a different town, like I can jump out of my car and go for a quick run. And I find it's just like a really quick, easy way to really also, I like to talk to my patients about not focusing on weight when they exercise too, but focusing on like feeling good about your body, right? And like, I just have to say, like running, like I go for a run and I'm just like, my body is incredible. Like I just ran for 3 miles, and it's just like really like, I guess being intentional and spending some time reflecting, I think leads to better outcomes for me than going, what does the scale say, right? And focusing on that outcome. And then I also I've done yoga since like, I guess 2002 was when I took my first yoga class. So for about 20 years, and I like to intermix yoga into my week. It takes a bunch of different manifestations. Sometimes I just like jump on my mat and do what I feel like my body needs that day. Like a persistently annoyed IT band, so I'm always after that, and then I also use, and I think it's a really cool app. And as a physical therapist, I totally recommend checking it out. It's called Athletes for Yoga, and it's really an app that has yoga routines that are not super long. They're not like hour and a half long classes. They're most commonly between 5 and 30 minutes, and they're like targeted yoga sessions for particular athlete problems. So she works with a lot of runners, a lot of triathletes, and a lot of swimmers and bikers. So there's like, a video for like how to warm up to go for a long bike ride. There's also lots of like, it's like, here's the runner's knee series, right? And all these things that you can do for runner's knee and IT bands. So I think it's a really cool app, and I like it because I can use just like little 5 to 20 minute classes to do little resets. And I also like a lot of the strength based classes because they're very targeted to like the particular weaknesses that runners have, and particularly female runners. So really building up things like, building up strength in the hip and things like that. So, so I love doing those. And then I'm also a big walker. I take my dog. I have a dog named Eddie, and he and I
Hmm.
walk at least once a day, if not twice a day. And I really try to get outside and just like do a little like walking meditation, basically. Just try to be in that moment and only in that moment and walk around and, in the winter, take in the snowdrifts, or right now at least get to take in the blooms and what's kind of growing in my neighborhood, which
Eat the wind that comes off the lake.
exactly.
No, I
Get
think
to
it's.
take a good selfie with frozen eyelashes and
Mhm.
send them to all my friends who live in places like California who are like, what are you doing with your life? Oh my
I,
God.
I remember I remember the first semester I was in Buffalo because that's where I went to grad school and undergrad, and there was a week in February. I remember calling my dad, and I was like, "It's like -28 here, and the wind chill makes it like -38." And I walked outside, my nostrils were completely frozen. I mean, I had like 4 layers on, boots, everything, and I was still cold. And
Cool.
so I live in California now, so
I'm
I
like,
couldn't
and
handle the
then
cold.
you moved to California. I wonder about
Yeah, I
that.
know. Um,
I
but there's
know.
a
I
reason for that.
yeah, exactly. And directly correlated, you got your butt to California. I know
Yeah.
I walk in the winter in what I refer to as my upright sleeping bag. Like it's literally like a sleeping bag in coat form.
Yeah,
It's great.
yeah, yeah.
Great.
And I think it's good that you work out because I mean, if it's hard to tell patients to work out or be fit or live a lifestyle that's good when you're not living that one yourself. So I
Yeah.
think that's good that you lead by example by doing that. And also, you're just you're in the trenches. Like I can condone you what you're doing with like all the legislative and law and all that. Like you're really like you're on top of it, and that's awesome.
Thank you. I appreciate that. I
And
appreciate that. I also, I was really lucky to have some good mentors in residency around healthy habits. And, I'm a really big fan of just like trying to know the people who grow your food and trying to remove like, patients come into me and they're like, should I be on the paleo diet or the keto diet? And I'm like, I don't care about diets. Like, I don't want to hear about diets. I want you to look at your plate and go, wow, it's mostly vegetables. Like that, look at your plate, it's mostly vegetables. Look at your plate. Are there lots of colors on your plate? And then I talk about trying to remove like processed foods from your life. So if you look at a food and it's got more than like 5 ingredients in it, probably like not the best thing for you. So, I talk about people like trying to buy things that don't come with labels, that's often fresher. And obviously, this is not like universally able to happen, but trying to kind of build up those habits of um, eating the rainbow. I think like I try to tell people, just try to eat the rainbow and then eat everything else in moderation. I think you'll be fine.
I agree. I definitely agree. And there's definitely a lot of diets out there. And I think you touched on something earlier with not being so associated with your weight. And I think looking in the mirror and just having a good diet, I think that's more important. And being okay with the way you look in the mirror is way more important than what a number is on a scale. Because like for me, I did a test on Thanksgiving. This is probably embarrassing, but I did a test on Thanksgiving one year. And I was like, how much weight can I physically gain from one meal? And so I didn't eat anything at all morning, anything. And I weighed myself right before Thanksgiving. I was 190 pounds. After the meal, it was like 3 plates later, I weighed 200 pounds. I gained 10 pounds of food. I was 5% food at that point in my life. And I was like, I think it was really then I was like, okay, weight doesn't matter. It's really just it's about everything you're eating and everything else. So
Yeah,
it's
yeah,
one. I felt great after. I didn't feel sick at all, but it was definitely a learning lesson for me personally to be like, wow, okay, weight is definitely not just a number on us or just this arbitrary number that's what we are. It's a moving number, a moving target.
exactly. And I swear, I find the more perseveration with numbers, the harder it is to achieve a good outcome. Like,
Hmm.
I think when people are really able to focus more on like feeling good in my body, feeling healthy, feeling strong, those outcomes to me are much more important than a certain number.
Yeah.
which I mean, Western medicine doesn't back me up at all because they check your weight every time you come in and they categorize you by your BMI, but you know, yeah.
So it is. So it is. Well, listen,
Exactly.
it's honestly been great talking to you. I think we're already coming to the closing here, and I want to ask you a couple of questions before we're done. And this is the Health Me, Health You closing questions.
Awesome.
And so the first
Drum
question
roll.
is, if you had the attention of everyone in the world for 30 seconds, what would be the one thing one thing you think you could say that could change the way we looked at Planned Parenthood?
This is a really fantastic question. So I think what I would say to folks is to remind ourselves that you never know what's happening in somebody else's life. And so to try to remove that ability to judge someone just on first blush, because you really don't know what is actually happening in their life. So, as an abortion provider, I have the opportunity to sit and hear patient stories. And I often chat with them, as I'm providing their abortion and hear what they're going through. And I could write a book. My friend actually has. Her name is Mira Shaw, and it's called You're the Only One I've Told. But often I feel like if I could somehow present those stories to the world, people would go, wow, I shouldn't have judged that woman. Or if I had only known that she was going through these 10 or 15 things that led to that decision, maybe I would have approached this in a different light. So just a reminder that you never really know what people are going through and what they've had to get through to get to the point where they are. And so, yeah, that was kind of a rambly answer, but to
No, I
remember that everybody's got their stuff they're going through. I think the most surprising fun story I have, which is a little bit longer than 30 seconds, I'm sorry, but one time I took care of a patient who had flown back from a military base, a US military base in South Korea, because she was pregnant and couldn't be. You can't access abortion and you can rarely access, well, you have limited access to contraception in the military. And so she had a 72-hour ability to get off base. So she flew from South Korea to Buffalo, New York, and back in 72 hours to be
Oh
able to
my
not be
God.
pregnant. And and I think to myself, that is a person who we say support our military, support our troops. Yeah, let's support our military and support our troops by giving them access to the healthcare that they need to
Yeah.
be able to take care of our country. So
And
that's
not to
one
fly
example.
72 hours halfway around the globe. My God.
I know,
That's
crazy.
insane.
Yeah,
Uh,
yeah, yeah. I know. As I was like, wait, did you just say you flew from South Korea? I was like, what?
am I hearing that right?
Yeah, exactly. Sorry. Second question.
Second question. How do more people know about you if they have questions or perhaps they live in a state that isn't as friendly as New York is?
Yeah, absolutely. So the first thing I would say is plannedparenthood.org is a great jump off site that will connect you. You can put your zip code in and it will connect you with local Planned Parenthood resources. There are also, oh my gosh, I got to look up. There is something called Planned Parenthood, and it's a direct service online. It has a cute little name, Planned Parenthood Direct. If you Google Planned Parenthood Direct, you can actually access birth control and a few other services, treatment for UTI, from an app on your cell phone. And that's a national program. So
Hmm.
plannedparenthood.org is a great website for information. I always say, if you want information about abortion, do not Google it. You will not get information that is accurate. I can guarantee it. But if you go to plannedparenthood.org and read our pages on abortion, you'll get a lot of good fact-based information about abortion. And then Planned Parenthood Direct, you can directly access birth control and UTI services from your phone. And then for me, I'm actually working on expanding a little bit into social media spaces and doing a bit more education. I have so many friends who are like, we call you and we ask you all these questions about which birth control to choose. You should share this with the world. So my Instagram is dr.amypk. And so that will be open to the public. And I'm going to start doing a little bit more informational and educational sessions on my Instagram page.
That's
And then I
great.
suppose eventually I'm going to have to get a TikTok, but I'm like old, so I got to work up to that. Okay.
I'm doing the same thing. I just downloaded TikTok and I like put it in the back corner of my phone so that way I don't get like addicted on it and like go down these rabbit holes. But yeah, I'm gonna have to eventually get on there as well.
And then lastly, I'm on LinkedIn and my name is Amy Potter and I'm associated with Planned Parenthood. So I'm pretty easy to find on there.
Perfect. And so I got one more question too. How much longer do you plan on being an Eagles fan, and when do you plan on becoming a Bills fan?
That is such a good question. I love it. So I grew up in New Mexico. That's where I was born and raised.
Mm,
And a lot of people in New Mexico like the Cowboys. And I just grew up being like,
Eagles.
I hate the Cowboys. I don't like them at all. Like, I don't know why people in New Mexico want to associate with Dallas, Texas. And I was like, I was basically anti-Cowboys. That was like my whole affiliation growing up was like, I hate the Cowboys. And then I moved to Philadelphia for college and they were like, no, 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 no. We hate the Cowboys. And I was like, my people, this is amazing.
That's
So
funny.
I became an Eagles fan. We also won the NFC championship like 2 of the 4 years I was in college. So that made it easier to become a fan. It was the Donovan McNabb era. It was
Uh,
lovely.
oh, I'm a
Um,
Giants fan, so I'm not a fan of the McNabb. So
I'm so sorry. Like, this has been such a wonderful conversation. I'm glad we didn't get to that until now. No, I'm
I
just kidding.
know, yeah. Well, we got
So
2 Super Bowl wins under our belt, so we're good.
exactly. But I gotta tell you, I will always be an Eagles fan first and foremost because I love how snotty our fans are. And there's just too many good stories, and throwing snowballs at Santa is the best. But I am so impressed with Buffalo's fan base. It really is like they're like the most heartwarming, lovable fan base. Like they routinely figure out the charities of like the people they've beat and then donate to them. I don't know if you heard about this with
Oh
the
yeah.
Cleveland Browns. I mean, so it's kind of hard to hate on Buffalo Bills fans because they're like literally the nicest. So I was totally cheering for Buffalo this year when everybody else that I like had any stake in was completely out at that point. I also just love to see Tom Brady lose.
Yeah,
So
I think everybody does. I was gonna say
exactly.
one of the biggest things I saw a difference from East Coast and West Coast was sports. I mean, the diehardness of sports on the East Coast versus the West Coast, it's night and day. And I tell people all the time, going to a Bills tailgate is like unlike anything else.
It's
Like I've been to several other games and it's just not, it doesn't compare.
It totally does not. I gotta say, Bill's tailgate is amazing. And then there's this whole thing of like jumping onto tables. Have
Oh
you seen
yeah.
that?
Hmm.
Yeah, amazing. So who did they just draft? I forget who the Bills just drafted. I think a new.
Uh,
I would have to look it up, anyways.
yeah.
But this like 5-star recruit, the draft pick, like jumped onto a table. My husband and I were like, "What is he doing? He just like signed a multi-million-dollar contract." But of course, all the Bills fans were like, "Whoa, we love
Hmm.
you!"
I don't know. I
Yeah.
don't know if you see the little baby videos where they'll take a baby and they'll like gently like push it through a little table. I'm like, wow, that really is initiation to the Bills fandom.
I love it. I love it. Yeah. Hey, and God bless them because they go out and they watch football games in sub-zero weather.
Yes, they
So
do.
respect,
Yeah,
respect.
respect for sure. Well, listen, Amy, it's been excellent talking
I
to you,
love it.
and thank you so much for coming on and sharing all your information. You are certainly smart and very, very dedicated to what you do. So thank you for everything that you do.
Absolutely. This has been really fun. Thanks for giving me the opportunity. It was fun.